ये क्या हो गया? शोर हो रहा है। हाँ यहाँ से ओ जो अब कटेगा तुम्हें याद है ना, ब्लड इतना आया था पता नहीं चलेगा। वही है अंकित हो गया है। ये पहले वो ये वाला काट दे, अभी ये भी काटना, अभी पड़ा है ना तो। ये नहीं काटता मैं।
Hello everyone, can you hear me? Can you hear me?
Yes, yes.
Mm. Right, so let's start. So this is the first case. A 30-year-old female patient with a background of sickle cell disease has presented with chest pain. This is the blood film. I would like you to enumerate the findings in the blood film. So this is power 10. You will have one question in the exam which will say list the features or list the findings in the blood film. It will not say to report the blood film. It will say list the findings in the blood film.
Yeah, there's a lot of nucleated RBCs there. Hemolyzing.
Yeah, so this is power 10. I will go to power 50 to make it clear, and then you have list all the findings that are there.
Target cells.
Okay. Anyone else?
This could be like a variant, like an SC or something like that. Sickle
He's
cell.
a known sickle cell disease patient, has come with pain.
Yeah.
But the question is, what are the features in the blood? List the features in the blood.
Yeah, you see sickle cell quite clear. Target cells, nucleated RBCs, thrombocytopenia maybe. What's the platelet count?
Platelet count was 340.
Okay. Oh. There's anisotosis as well.
Are there some plasma cells?
No, these are not plasma cells. These are NRBCs.
Because the
So
nucleus is a bit eccentric. Looks a
yeah,
bit-
but these are not plasma cells. The nucleus is very small, and the cytoplasm is not bluish, just like the plasma cell. And the plasma cells borders are not straight. The plasma cells borders are wavy or flame shaped, and the plasma cells are bigger than RBC. So if there is a finding and you did not mention it in the exam, you will lose a mark. Everyone knows that this is sickle cell crisis, but what are the features in this blood film?
Target cells are prominent.
So they are target cell. This is 1 mark. What else?
Well, you can see the sickle cell there.
Sickle cells. What else?
Strange looking neutrophil.
Mm-hmm.
Anisotosis. Different sizes.
What is this one?
Yeah, it's a macrocyte.
Now, this one or this one?
That could be spherocyte.
These are spherocytes. Patient is sickling.
Spherocytes. Yeah.
So you
Yeah.
have to mention all in the exam. Otherwise, you will fail the question. And you you guys know that I have shown you the result of the people in which the people failed by 0.5 marks. The whole exam was failed just for 0.5 marks.
Mhm.
So you have to pay £1,500 again. So if they are asking you list the features in the blood cell, just number 1, sickle cell, number 2, target cell, number 3, NRBC, 4, spherocyte, 5, reticulocyte, 6, uh, few large platelets over there as well, granulated neutrophils over there. There were few Hubble jolly bodies as well.
Oh yeah.
You have to mention all the features, otherwise they will have a list of features with them. If you have not mentioned that in the exam, you will not get marks. What is the difference between this cell and electrocyte?
Well, there's more curve to the sickle cell. The shape.
So
And
electrocyte,
pointed edges,
Yeah.
pointed tips.
Sickle
what about
cell.
this?
Yeah.
Sickle
Cancer
cell.
cell is more
sickle cell.
straighter, rounded edge.
Which one has the central pillar? Sickle cell or electrocyte?
The leptocytes.
The site.
Electrocytes. Electrocytes.
Because a sickle cell patient may be iron deficient as well, and iron deficiency can lead to electrocytes. And this is a Howell-Jolly body. Okay, but why this patient has target cell?
I'm saying it could
Because
be
of
combination.
autosplenectomy in most sicklers.
Okay, so don't use the word sickler. It is an offensive word now.
My bad, sorry.
Okay, so if there are Howell-Jolly bodies or if there are target cells, it means the patient has hyposplenism. Okay. Here we have a lot of boat-shaped cells and sickle cells, and at the bottom there is Howell-Jolly body. All right.
Okay.
Diagnosis is easy in the exam, but the full question carries 10 marks. You have to get a minimum mark to pass the question and to pass your exam as well. But it would come with practice if you have your own slide bank and write on the paper what is the report or features or what the next step of treatment, acute treatment, then you will be able to go through the exam.
Dr. Ahmed, why can't it be sickle beta thalassemia? Because in it also have target cells and NRBCs.
Yeah, so this patient is in crisis. If the patient is in crisis, he is hemolyzing a lot because the patient has spherocytes, reticulocytes, and bone marrow is under stress. That's why the NRBCs are coming to the blood. And the target cells are there because the patient has hyposplenism. And there is another evidence of hyposplenism, which is the Howell-Jolly bodies. If this patient has sickle beta thalassemia, there would be some degree of microcytosis and hypochromia as well in this patient, which was not present in the blood film.
Okay, sir.
Right. So the second case is a normal adult patient, 30-year-old, and he has come to your apheresis unit for stem cell collection. And this is the blood film because the lab scientists have noticed that the white cell count is very high. This is power 10. So what does the lab scientist or lab hematologist think about that?
Neutrophilia.
Okay, so why he has got neutropenia?
Most likely
What are the differential diagnoses of neutropenia?
GCSF.
Others?
They are mostly left shifted, so I think it could probably due to the GCSF that he had for the stem cells collection.
Yeah. Otherwise, it could be infection or steroids.
What else is the differential diagnosis of neutropenia?
Is it CNL?
Okay. Yes, reactive GCSF, CNL. If you mention 3 or 4, that is enough.
Sorry, what's that's abbreviation?
Sorry?
What's his
CNL.
name?
CNL is chronic
They-
neutrophilic leukemia.
So causes of neutrophilia are the leukocyte reaction, post-infection, steroids, use of the GCSF. It could be a secondary malignancy, CML as well, or it could be chronic neutrophilic leukemia, which is very rare.
Yeah. So how would you differentiate GCSF-induced neutrophilia from other causes?
So from the leukocyte reaction, mostly the neutrophils will have toxic granulation and toxic vacuolation if it's due to infection. And steroids, perhaps it would be the same. For the GCSF, it will be mostly left shifted, like the hyposegmented features. And for the CML, they will have like myeloid peak as well. So there would be like a lot of myelocytes, like two peaks, neutrophils and myelocytes. What else did we say? And for the there is no specific feature for chronic neutrophilic leukemia. There will just be lots of neutrophils, which of normal morphology.
So
Platelet
CML,
count.
sorry?
Oh, the platelet count looks a bit low.
Yes. I think that these are normal platelets, not low. He has enough platelets, almost 8 platelets in this field, power 50.
It looks more like a toxic picture. Cytoplasmic vacuolation, toxic granulation.
Mm-hmm.
The reds look okay though.
So the history is telling you he is a normal man and attending the apheresis unit for the stem cell collection. If he had fever or any features of infection, there would be a lot of toxic granulation in these neutrophils. But this patient has granulation, the orange granulation. He may have, we will see now, myelocytes as well, left shifting. There will be a lot of band forms in this patient as well, because the whole of the myeloid series cells, they will appear in the blood film. Even there may be one or two blasts as well, this one. But in CML, you will have basophilia, eosinophilia, must be there as well. So history and few of the features of the blood film will tell you this is GCSF induced, or this is infection induced, or if this is CML. If this patient has a solid organ cancer and in the history, no GCSF history, then yes, leukocyte reactions are secondary to solid organ cancers as well. In case of CNL, chronic neutrophilic leukemia, all the cells are mature. All the neutrophil cells, they are mature. More than 80% neutrophils that you will see in the blood film, they are mature neutrophils. There will be no band forms. There will be no bluff. And another important thing to differentiate CNL from the rest of the neutrophilia causes is the mutation. CNL has a specific mutation, and that is what is the mutation of CNL?
CML's BCR-able.
CNL, chronic neutrophilic leukemia.
Oh, right, sorry.
Clinical. This is a 2-mark question in the exam. It is CSF 3R. Things which are not rare in real life, they are common. Things which are rare in real life, they are common in the exam. So be ready for the CNL cases or TPLL cases or LGL cases in the exam. You will not see them in real life. I haven't seen any CNL case up till now. But the NICWAS slides or in the exam, yes, they will appear. So this GCSF induced blood film has band forms, has a lot of orange granulation in the neutrophil. You will see myelocytes as well, a blast, GCSF induced blast in the peripheral blood as well. Patient is usually normal if he is an allogenic stem cell donor. There will be no history of fever, no history of solid organ cancers in the patient. There will be no basophilia in the blood film, no eosinophilia in the blood film. Okay. And if you have a transplant unit in your patient, you can see the blood film of a normal people with GCSF. But if not, you may have a lymphoma patient or myeloma patient in your units. When they receive GCSF, you can check their blood film to differentiate it from CML and sepsis-induced leukomoid reaction. In sepsis-induced leukomoid reaction, you may see a lot of NRBC as well, because bone marrow is very much under stress. And why we don't give GCSF in AML and MDS? Clinical, why we don't give GCSF in AML and MDS?
Can induce the cancer cells proliferation.
What are the cancer cells?
The myeloid series is involved. That's why we don't give the GCSF for that.
It brings blast to the peripheral blood film, and the blast percentage increases falsely. So if your patient has GCSF injections and you have sent blood for flow cytometry, they will say the patient has 22% blast. And the MDS patient will be considered as AML now. It increases the blast percentage in the peripheral blood film. That's why we avoid GCSF in the AML cases or in MDS. For those patients who are on palliative line and they are not responding to intensive therapies and not candidates for allogenic stem cell transplant, then if the treating team decide to give GCSF because of prolonged neutropenia, then we can give them GCSF. Otherwise, in the routine, we don't give them GCSF. So
After the Hydra, can we give the GCSF as well if the patient suffers from neutropenia?
sorry.
After the hydroxycarbamide, can we give the patient GCSF if the patient suffers from neutropenia after the hydroxycarbamide?
What is the cause of neutropenia in this patient?
In this patient, I'm asking about the hydroxycarbamide. If we give any patient
Yes. What is the cause of the neutropenia in hydroxycarbamide treated patient?
the myelosuppressive effect of the
And who causes myelosuppression?
Hydra cause myelosuppression.
Okay. So it is hydroxycarbamide induced myelosuppression. Stop the hydroxycarbamide, counts will come up again.
Okay. So there is no need to give the GCSF for that.
No.
Even
But when we have a secondary cause for neutropenia, that this is the hydroxycarbamide induced, we have algorithm in the BSH guideline for hydroxycarbamide. When should we
yeah,
withhold or stop
we stop
hydroxycarbamide?
and we. So what are the basically indications for the GCSF
So GCSF one is this
in
one, mobilization of stem cell, and another one is chemotherapy-induced neutropenia in lymphoma and myeloma cases. We give routinely because they are a part of the regimen.
okay.
These are two main indications of the GCSF: mobilization of stem cells and increasing the neutrophil count in lymphoma myeloma cases.
Okay, in lymphoma and myeloma. Okay.
Yes, because
So
we
can
are
we
doing autografting in lymphoma myeloma. So
Dr.
this
Amir,
is-
can we give GCSF in neutropenic patient in hypocellular marrow like aplastic anemia if there is an increased risk of infection and there is very low neutrophil count?
they
So is
don't
there
they don't have any functional marrow. The aplastic anemia patient have all um, like fat cells in their marrow. We don't have anything in it. If there is any marrow left, then yes, we can give them. But in the routine, we have nothing in the marrow of a aplastic anemia patient to mobilize them from marrow to peripheral blood.
okay, then what is the standard of care? Means if there is a patient is not responding to the antibiotics and patient is going in sepsis, so
Yeah,
what will be the standard of care?
so the routine here is that if the patient is septic, we treat the sepsis. And after sepsis, we know that this patient will have low cell counts. Okay. If the neutrophil count is less than 0.5, these patients are on long-term antibiotics. Prophylaxis antibiotics, levofloxacin 500 milligram once a day.
Can we give the granulocytes infusion?
So granulocyte infusion is always after a discussion of MDT. It has its own specific indication. When you think that this patient neutrophil count will recover, then you give the granulocyte infusion. When you don't have any marrow left in aplastic anemia, so then there is no way to recover the for the neutrophil to recover. So we don't give granulocyte infusion in aplastic anemia patient.
Okay.
If it is an adult patient, he will go for stem cell transplant. So his misery will be over soon. If it is an old patient, then we have to try ATG and cyclosporine for. Hopefully that will solve the problem.
Thank you.
So this is a 23-year-old female patient who is having fever And lymphadenopathy. The full blood count shows that hemoglobin is 122, white cell count is 17, and the platelet count is 210. The blood film has gone to lab scientist or lab hematologist first. Let's see if he thinks this is lymphoma or leukemia. This is power 10.
Lymphocytosis and neutrophilia.
Okay, so do you think this patient has lymphocytosis and neutropenia? Let's go to power 50 then.
Looks more reactive.
Why do you think this is here?
Well, it's the large cell that molds around the reds. Slightly basophilic cytoplasm. Not classical though.
So if the cytoplasm is basophilic and cell is large.
No.
Blast can be
Okay.
of lymphoid origin. Could be with the clear cytoplasm. It could be of lymphoid origin blast.
It is lymphoid because the cytoplasm is mostly clear.
Mm.
Just there were few blasts which have the like granules. Not in this one, but initially I've seen one with some granules.
It would be a granular lymphocyte.
Or LGLs?
LGL, yeah, that could be. Eosinophilic granules for that.
It was only one cell with
Yeah.
large granular
Yeah.
lymphocyte,
Mm.
with large granules or granule cytoplasm. But the rest of the cells don't have granule. And the cytoplasm is not clear at the basophilic. Right, so the lab scientists think that this is lymphoma because the patient has lymphadenopathy. He has read the history on the request form, and now he has referred the blood film to you. Clinical hematologist, report this blood film. This is a very common exam question.
Is it the L?
RBC are the normocytic, normochromic, and the platelet count is quite normal.
Adequate.
So who is this speaking?
I'm speaking, Dr. Sindhu.
Dr. Sindhu, you may have heard from me before that comment on the abnormal cell line count.
Okay. Can you repeat what was the CBC count in this patient?
The
Especially
hemoglobin was 122, white cell count was 17, and platelet count was 210.
WBC 70, 70.
17.
17, okay. So on the low power, maybe there is a leukocytosis, most prominent lymphocytosis.
Mm-hmm.
The BPLL.
And these cells are intermediate in size with
Which cell?
these cells are intermediate in size. These are intermediate in size.
These cells are intermediate. Okay.
Yeah, these atypical lymphocytes, these are intermediate in size with basophilic irregular cytoplasm, and nucleus is quite condensed, and it is also irregular in margin, and there is inconspicuous nucleoli. There's no any prominence of nucleoli. And while RBC, these are normocytic, normochromic, and platelet, they are adequate in the background. So the peripheral smear consistent with the maybe lymphoma or LPD, lymphoproliferative disorder. So what was the history on examination? Is there any lymphadenopathy or organomegaly?
Yes, this patient has lymphadenopathy. He has fever.
Is it the TPLL cell?
TPLL. So I mentioned to you before as well, concentrate on the history first. History may give you some clues as well.
There are not much counts. That's why it's
Okay.
not TPLL.
She is 23-year-old. She has fever and she has cervical lymphadenopathy. These cells are all basophilic. One of the colleagues informed me that these are reactive lymphocytes.
Okay.
Infectious mononucleosis.
So these are infection mononucleosis cells. None of the CLL cells are not like this. And you will not expect CLL in 23-year-old. Follicular lymphoma cells, they have their own morphology with a cleave in the center. Okay, and
So there wasn't so much clear scalping of the red cell around that. That's why maybe it's
you have seen many cells which has very clear scalloping, and these cells are basophilic, and a lot of cytoplasm is there as well. And you haven't seen any blast in this in this blood film.
So how do we differentiate between the lymphoma and because I have seen a few cells having scalping, but few lymphocytes are not much as reactive as in infectious mononucleosis.
The others you have seen are the granular type of lymphocytes. The granular lymphocytes are also secondary to infections as well. They will be clonal only if their TCR reagent is positive, a receptor is positive. And for that purpose, the patient should be elderly, should have history of autoimmune disease like rheumatoid arthritis or SLE, etc. And the patient should be afebrile as well. Which lymphoma you were thinking that this patient has?
As you said that large granular lymphocytes, maybe I'm telling that maybe there is LPD, lymphoproliferative disorder.
Which one?
So, large granular lymphocytes, because size are, these are large in size and quite few are granular as well. But there is scalping.
Okay.
So
So if in the exam you get a LGL lymphoma, they will give you a history of neutropenia and a history of autoimmune disease.
okay.
Okay. Secondly, this patient has whole jolly bodies as well. You miss that in your reporting, you will lose marks for that, because the examiner report has mentioned the RBC contains whole jolly body.
Okay.
Yeah. So always concentrate on the history. A 20-year-old cannot have a CLL, and follicular lymphoma has its own morphology. Mantle cell lymphoma has its own morphology. Waldenstrom cells or marginal zone lymphoma has its own morphology as well. They are not like this large cells with basophilic cytoplasm, and there is prominent scalloping. This cell is scalloping to 4 RBC, you know. So this is a common scenario in the exam. I think it did not appear in the last exam, so this exam it will appear for sure. These large cells with scalloping, and especially this is scalloping to the band, this one is scalloping here, very prominent basophilic as well. So the next case is again 30-year-old with
Sorry, I'm for the
abnormal full blood count. Sorry?
sorry, the previous case was an LGL then.
No, it was infectious mononucleosis.
All right.
In LGL, the scenario would be that a 56-year-old man with a previous history of rheumatoid arthritis or ankylosing spondylitis or Sjogren's syndrome was referred to you because of neutropenia. And there will be a lot of LGL cells in their blood film. Let me check if I have any LGL case here.
Dr. Amit, the granules, you said in infectious mononucleosis, there could be the granules in the lymphocyte as well. But is the granules will be the same as in LGL, or that would be the different one?
Same as LGL.
Mm.
I think the slide has become old and the stain has eaten the white cell. I will try to bring LGL slides for you because this one is now old and some of the this is one of the large granular lymphocytes.
I really cannot appreciate the granules in that.
Yeah, because this slide has become old and like they appear like moth eaten.
That looks a bit granular.
Any other? Mhm. Okay, if I manage to find another LGL slide somewhere, and this one has nice granules. This one has also granules at the top portion. Is Mark with us?
I am indeed, yes.
Do you have any fresh LGL slide with you? I have this one, but this one is old and the stain has.
No, I can't say I haven't seen many LGLs.
I always see the blood film of autoimmune disease patient and I hope to find LGLs in them.
What is that? Is that a lymphocyte again?
Yes, but the stain is expired now, so the white cells appear very strange. So that's why I'm looking for some nice LGL which is prominent.
Staining is a bit strange too. It's not an MCG stain, is it?
Yeah, but it is an old slide. It's more than 1 year old now. So the stain has worn out.
Yeah.
So I will try to produce LGL from here. Right. Let's go to our own case. This is a 30-year-old male referred by GP because of the abnormal full blood count. Hemoglobin is 140. White cell count is 13. Eosinophil count is 5. And platelet count is 250. So what do you suspect if this is the full blood count of a patient?
Seems to be a lot of eosinophils, maybe reactive.
Failure. Mm,
Okay.
Yeah, eczema or like helminthic infection.
What infection?
Worm infestation, helminthic.
Worm infestation. So if you are sitting in the exam, what will you do to find a worm?
Go low power. And
So first you will go to low power. If there is any eosinophilia case in the exam, which the RB or the full blood count shows that the eosinophil count is high, you should start from power 4, because in the Nico's blood film, they have a lot of worms in the Nico's blood film, and it is difficult to miss them. But in the exam cases, they will have one worm per slide. You have to go through all the section of the slide quickly to find them. They appear on power 4. And if you could not find eosinophilia, you could not find worm, then you will go for other causes of eosinophilia.
Have you got a travel history on this job, the patient?
Sorry?
Have you got a travel history?
This was the point that you snatched from my mouth. I was about to say it. That if the scenario says that this patient has traveled to anywhere, African countries or South American countries, then certainly there is a worm, but you are missing it. Okay? So this patient does not have a travel history, but the eosinophil count is persistently high since 2 years, sometimes 5, sometimes 6, sometimes 4. This is the blood film.
What's the CRP like?
The CRP is normal.
Yeah.
Is there any history of asthma or any allergic condition?
No asthma, no allergic condition.
Steroids?
No steroid. He is a young man and completely fine. No background medical history.
Is the eosinophil dysplastic?
That you have to tell me.
Yeah, that's not correct. You'd expect more bilobed than the granulation. Be orange granules.
So what are the clonal causes of eosinophilia?
Chronic eosinophilic leukemia.
Myeloid and lymphoid with mutations like PTGFRA, PTGRFP, FGFR1, and acute myeloid leukemia, especially inversion 16, and acute lymphoblastic leukemia, but there is translocation 514, but there the eosinophilia is secondary to the reactive cause, not due to the clonal. And mastocytosis and other causes is like CMML. There is also can be a mutation which leads to the eosinophilia, and other not otherwise specified cause, especially
There is no not otherwise specified cause anymore after WHO 2022.
Okay,
If you want to mention it, you have to write in bracket that you are mentioning ICC.
Okay, it can be yes, I remembered.
So chronic eosinophilic leukemia is one. Myeloid lymphoid neoplasm with eosinophilia and tyrosine kinase fusion is the second one. And if both of them are not present, then it is called idiopathic eosinophilia. What is the difference between idiopathic eosinophilia and idiopathic eosinophilic syndrome?
So the one has the organ damage, like idiopathic eosinophilia syndrome has a organ damage caused by the interleukins released by the eosinophils, and the idiopathic eosinophilia in which there is no any organ damage. So this is called idiopathic eosinophilia.
Okay. The idiopathic eosinophilia is just eosinophilia. But if it comes with symptoms, then it becomes syndrome. Okay. You have mentioned the different genetic mutations that are present, rearrangement that are present in clonal eosinophilia, PDGFRA, FRB, and FGFR1. And you have mentioned some causes of eosinophilia as well, the myeloid and lymphoid causes. Right. If this patient has idiopathic hypereosinophilic syndrome, what is the first line treatment?
So the first line treatment.
Steroids.
First line treatment is steroid. If the patient is steroid refractory, then
Imitinib, low dose imitinib. Imitinib 400 mg for 6 weeks at least.
okay, right. The eosinophilia is a common viral case. You should remember what is the treatment of idiopathic hypereosinophilia syndrome. What is the treatment of clonal eosinophilia with PDGFRA mutation or FRB mutation or FGFR1? So before winding up this case, anyone can report this blood film for the example.
So this blood film is showing prominent eosinophilia that are bilobed and with eosinophil precursors as well. And there is red cells are normocytic normochromic, and the platelets is normal in morphology. And I cannot is what there.
Is the dimorphic picture or no, like some normocytic and some few hypochromic?
There is a bit of hypochromia, and that's it. Your report is not complete yet.
There is little I'm seeing vacuolation in eosinophils as well.
Because they are dysplastic eosinophils. That's why you are seeing vacuolation. To complete your report.
Means basically I would like to see neutrophils as well in this patient. There was no blast, however, and was no neutrophils are also evident, right?
There is no neutrophil here. It's all eosinophil.
Neutropenia. Right.
Okay. Complete your blood film report.
So, how to complete it? I'm actually not getting it.
You have commented on the blood cells. What is this? What is your impression? And what is your suggestion? The GP has
Okay.
sent this blood film to you.
Oh, okay. So the blood film is suggesting of increased eosinophilia. I will request to GP have a detailed history and examination, and with a stool for ova and cyst, and CR to look for the CRP and infections to rule out the secondary causes.
GP know about that. Give him hematological advice.
Okay, then I will advise him to PDGFRA and PDGFRB, FGFR3 mutation, peripheral blood.
I will ask the GP to
Bone marrow biopsy.
observe the patient for the symptoms for some duration.
Patient has eosinophilia since 2 years.
Bone marrow biopsy. Cytogenetics.
So the blood film shows leukocytosis, most of which are dysplastic leukocytes. There is a bit of hypochromia in the red cells, and the platelet count is down. So this patient has eosinophilia, which can be primary and secondary. For hematological reasons, we will send a blood sample for fish and a serum tryptase level and immunophenotype. And after that, the next step will be a bone marrow biopsy and cytogenetics in the outpatient.
Dr. Rekha, can you please mute here?
Okay, sorry.
You said that history examination, then serum tryptase and the immunophenotyping for that patient.
The history examination will be done by the GP. He would have done that to exclude secondary causes. He referred to you because this patient has eosinophilia since 2 years.
So I will ask for the serum tryptase and immunophenotype.
Yes, for clonal causes, you need a peripheral blood sample for fish.
Okay.
In the bracket, you can write for a PDGFRA, FRB, and FGFR1 or FIP1L1, flow cytometry, and serum tryptase. If there is any clonal cause, you will get it on these tests on FGFR1, on the peripheral blood flow fish, and on the immunophenotyping and tryptase.
Okay.
Why we are doing tryptase for this patient?
For
Systemic mastocytosis. The eosinophilia panel consists of fish, immunophenotyping, and serum tryptase.
Dr. Amir, can we advise the serum vitamin B12 because it is also a marker of T clonality, as I read in the books.
The GP would have done that.
Okay.
We only say if it is a new case, we advise the GP to exclude secondary causes. If secondary causes are ruled out, please refer back to us. And GP knows what are the secondary causes of eosinophilia. Hematologists are not required to exclude secondary causes.
It is also written that in the treatment we have to give strangulite cover, whatever the reason or whatever the underlying cause. So is that true that we have to give in every case?
It is only for I heard that for ATLL patients, but not for the strongyloides in the eosinophilia. If strongyloides infestation is not the cause of eosinophilia, why should I give the treatment for that? Because we have many eosinophilia patients in our clinics, but they are not using any worm-related help. If it is ATLL, then yes, that is associated with strongyloides, and for that purpose, you have to give strongyloides cover. Otherwise,
it is written in the BSH guideline. I mean,
no. If it is the cause, then you have to give strongyloides cover. Otherwise, eosinophilia patient, if the patient has clonal eosinophilia, why would I give strongyloides cover? If you can screenshot that paragraph and send it to me, because this is not the practice that we do.
Okay.
And if it is related to strongyloides, induced eosinophilia, then the patient would go to ID, infectious disease, not to us. So this is the last case. So among the exam candidates, Harmeet, I know you are the exam candidate. So this is a 7-year-old boy who has been referred to hematologist because of recurrent epistaxis, spontaneous epistaxis, and the blood film goes to lab scientist. The lab scientist has noted thrombocytopenia in this patient. This is power 10. Are you there, Carmen? Carmen is silent. And another person that I know going for exam is Rekha.
Yeah.
This is
You
a
have done
7-year-old child with recurrent epistaxis, and the lab scientist says that this patient has thrombocytopenia.
So nuclear RBC there.
Mhm. So you are from the lab side, okay?
Yeah.
We need your comments first before referring this to clinical hematology.
Well, it's the thrombocytopenia that the age of the child is concerned. I'm looking for blasts, but I can't see any.
These are reactive left side. Okay. So you have referred the case to clinical hematologist because of thrombocytopenia.
Yeah. On the age of the child.
So Rekha is your clinical on-call hematologist. You have called her and she has come to lab to review the blood film. Rekha, report the blood film.
Okay. So the blood film is showing marked thrombocytopenia with platelet anisocytosis. There is a leukopenia. Neutrophils, please go inside to see the neutrophil.
There is very few neutrophils in this patient.
Yeah, so neutrophils are also evident, and the red cell morphology is also showing normocytic, microcytic, and microcytes, normochromic and normochromic cells. So the findings are suggestive of thrombocytopenia. That could be immune related, or that can be need detail in history, can be viral induced, can be drug induced.
What is this?
Oh yeah, how will
Jolly ball, yeah.
You need to mention every finding in the blood film, otherwise you will lose more.
Yeah.
I mentioned that this patient has recurrent spontaneous apoptosis.
The platelets looking larger.
Sorry?
This patient's got ITP. Possibly ITP.
Does
Large-
ITP patients come with recurrent bleeding?
A few large platelet can be seen with the thrombocytopenia, so I would investigate for the any inherited platelet as well.
What inherited platelet?
I don't know if it could be a
So
May
in the
Heglin or something like that.
large with the large size platelet, the main is the Bernard Solier and
Gray platelets.
gray platelet syndrome, but that doesn't look gray so, on morphology. But few looks like, but there are the evidence of a nucleated RBC. Somewhere I have seen some teardrop as well. So it could be with the gray platelet, maybe.
These are not gray platelets. The gray platelet is out of question.
So why there are the NRBC, UNRBC? Looks
These
like.
are not NRBC. These are large platelets.
These are giant platelet.
So the main differential with that was with the Bernard Solier.
What are the differential diagnoses of large MPV?
So it's May Heglin, Bernard Solier, gray platelet, Catch22, GATA mutation. So these are all in the Macrothrombocytopenia.
What else? Catch22 is not common. GATA is not common. Bernard is okay. MYH is okay. What else?
Von Willebrand type 2B.
Yeah, this is common. You need to check for that. Okay. So, Rekha should complete the report because you have to report this lesson for the example.
Yeah. So the findings are suggestive of macrothrombocytopenia. It can be inherited, but not solid. Or advised, patient is advised for patient need to be referred to the hematology clinic for secondary urgent management and diagnosis, and advised genetic mutation.
The blood film shows macrothrombocytopenia. The platelets,
Flow cytometry.
the platelets are granular. The red cell and the white cells are okay. The impression is that of inherited macrothrombocytopenia because of the given history. This patient needs further investigation to rule out the inherited platelet response. What investigations you would like to do?
First, I will. There can be light transmission aggregometry, immunofluocytometry, and genetic studies.
And resistatin.
And nucleotide
Use platelet aggregation, RIBA. For von Willebrand type 2B.
For storage, we will do the ATP ADP ratio for that.
So 1 milligram screen, peripheral blood flow cytometry, and a light transmission aggregometry. What is your expectation on light transmission aggregometry and flow cytometry if this is Bernard-Soulier syndrome?
So in the light transmission aggregometry, there will be absent response to ristostatin, 1.5 milligram high dose ristostatin. However, other will be normal. And in the Bernard-Soulier, I will get a CD42B.
CD42B what?
Positive?
Absent.
Absent, sorry, absent.
Absent.
Sorry, absent.
Not
absent.
positive. Be careful about that.
For GB12P.
GB95, 1B95.
1P. 1B9.
It is the glycoprotein which is absent. Okay. Right. So this was the last case. They were the general hematology cases today. And they will come to the exam. I'm not the examiner, but they will come to the exam. So be ready for that. Do you have any questions?
Sounds.
Any questions?
Thank you.
If no question, then enjoy the rainy Sunday for those who are in UK. And see you next week. Take care.
Okay, Amir. See you next week.
Thank you. Thank you.
Bye-bye.
Thank you.